Welcome to The Kick, your expert-led podcast helping you explore and learn everything about getting pregnant, pregnancy, birth and becoming a parent.
On the podcast and our online pregnancy program, Grow My Baby, we share my experience of helping more than 4,000 babies to be born.
And our experience of running a women's health clinic and parenting 4 boys.
We're here to help everyone to feel empowered in pregnancy and birth with real-life practical information.
Welcome everyone, I'm Brigid Maloney.
And I'm obstetrician Dr. Patrick Maloney.
And we've got a very special guest today, psychiatrist Professor Megan Galbally.
Yeah, Megan's an expert in perinatal psychiatry and also a lead researcher in that field.
Yep, and she's got a bio. I think it's important for our listeners to know that they're listening to kind of like the top expert.
It's very impressive.
Yeah, so she's the National Chair of Perinatal and Infant Psychiatry. She holds honorary positions at University of Melbourne, University of Western Australia, Murdoch University and University of Notre Dame. She's also director and a professor at the Centre of Women's and Children's Mental Health at Monash Health and Monash University, and is the lead in a longitudinal pregnancy study, Mercy Pregnancy and Emotional Wellbeing Study.
Fantastic.
Yeah.
So I'm already sitting up and taking notes.
Yeah, you really are. Like you've straightened up in the chair and everything. So let's move on and welcome Megan to the podcast. Welcome, Megan. Thank you so much for joining us.
Thank you very much, and thank you for the invite to be on this podcast.
Yeah, it's only taken us 6 months, 5 months?
I'm excited.
You're both very busy people, so I'm really grateful that you took some time off today to share your knowledge with our listeners. And I thought we might just start with some definitions. So if you could talk about just briefly what antenatal depression is, anxiety, postnatal depression, anxiety, and any other sort of issues that people might have heard of but don't exactly have a good definition in their minds and about it.
Yeah, thank you. And look, it can be really confusing because we blend some of the terminology that's used often in obstetrics and in midwifery with mental health. But basically for depression and anxiety, so two of the most common mental health concerns for women across pregnancy and the postpartum. And of course, now we're more and more aware that partners and fathers also develop depression and anxiety across pregnancy and the postpartum. We often think about it in pregnancy, which is antenatal, as in antenatal care, so antenatal depression, antenatal anxiety, so that's when it's occurring in pregnancy, and then postnatal, as in after the baby's born. And usually we'll define perinatal broadly from the beginning of pregnancy until around about 12 months, so when babies are around about 12 months of age. But of course, that ongoing importance of the relationship, of mental health, of parenting continues way beyond when a child is 1.
Mm. And with your background in psychiatry, I'm thinking people have picked this episode to listen to because perhaps they've needed a psychiatry either through their pregnancy or after birth. What are some of the issues that a psychiatrist would manage during a pregnancy?
Well, there is obviously depression and anxiety, so they're really important and very common complications in pregnancy and the postpartum. In fact, depression and anxiety are more common than any of the physical complications in pregnancy. So they are a big part of the work. But people who've had other mental health concerns in the past or may develop it for the first time in pregnancy or the postpartum. So this includes bipolar disorder, so that's often where people develop low mood, so depression, but also can have high mood, so hypomania or mania. Some people may suffer from schizophrenia or psychotic disorders, which again may need treatment in pregnancy and the postpartum by a psychiatrist. Obsessive compulsive disorder, so this has been in many movies and many literature, so people are familiar with this. That again, a really unknown fact is that new onset, so developing OCD for the first time, can happen in pregnancy and the postpartum, and it's not uncommon. Eating disorders, so anorexia, bulimia and other forms of eating disorders. Again, people may have had them in the past. They may become unwell in pregnancy or the postpartum and may need to see a psychiatrist. And for some people, they've had really significant trauma, either in their childhood growing up or in their adulthood. And again, this may influence and impact how they're feeling in pregnancy and the postpartum, as well as a whole range of other mental health concerns that people might see for psychiatrists. But they're some of the common things that people may see a psychiatrist in pregnancy or the postpartum.
And Patty, I want to ask you a question because, as a primary port of call, how do people present to you first, and then when would you, in a pregnancy, refer to a psychiatrist?
Yeah, it's interesting because there are two common scenarios, and Megan just touched upon those. One is, I guess, relatively. This isn't easy stuff for an obstetrician, but it's relatively easy if the person has an established mental health diagnosis coming into the pregnancy, because they'll have a really good psychiatrist that we can ring up and say, what should I do? Okay. It's often the obstetrician or the obstetric caregiver who's seeing the patient very frequently through the pregnancy and is aware that things are not progressing well for the patient from a mental health point of view, but then we might lack the expertise. So if the person's actually got an existing psychiatrist, fantastic, we can ring that person up and say, I don't think this is going as well as it should be. What else can we do? But the diagnosis of new mental health problems in pregnancy, I think, is a really challenging situation for the non-expert in mental health. And I think it's one of the reasons why it takes too long to intervene appropriately, is that we're not experts at picking up the early signs of significant problems.
And if it's the first time somebody's had exhibited any of those symptoms and it's during their pregnancy, there'd be that whole stigma attached. Do you feel like there's still that stigma about mental health, Megan?
Yes, certainly. Look, I think it's improved enormously. We've had some really successful campaigns and areas of focus led by organisations like BeyondBlue, but also the College of Obstetrics, I think, has taken a real leadership in advocating around mental health and seeing mental health as a core part of how we support women in pregnancy and into the postpartum. So we've had some really successful campaigns that I think have reduced, the sort of stigma and improved people's willingness to reach out and let their obstetrician, their midwife, their GP know if they're struggling. But we've still got a long way to go, I think. And particularly, I think, when people either for the first time or they start to relapse with some of these less common mental health disorders, so postpartum psychosis, which occurs for the very first time in the postpartum, I think still people can feel, all sorts of mixed feelings around that, and in terms of seeking care and what this means. And the same for people who've had trauma and who've had eating disorders and some of these less common mental health disorders. But I think for depression and anxiety, there's been a huge amount of work, and that's made a big improvement, I think.
It might be the first time that somebody has heard postpartum psychosis. Could you just give us a brief definition of what that is?
Yeah, so this is a really rare and uncommon mental health concern that occurs in the first 4 to 6 weeks after giving birth. It occurs in around 1 in 1,000 deliveries, so as I say, it's not common, but it is a really serious mental health concern, which certainly from a psychiatrist perspective, and I would think from an obstetrician perspective as well, it does require inpatient care. It occurs in women who've had no mental health history at all, so they've never been unwell, not with depression, anxiety, they've never had psychosis before, and for the very first time after giving birth, they develop psychotic symptoms. So these include sometimes hearing voices, feeling that their thoughts are under control. Their mood may both go up and down, so low mood and then elevated mood, perhaps all in a matter of hours. They may feel quite confused. They may have some odd ideas that are not in keeping with reality. And they may start to have thoughts that, life, for instance, is not worth living, or that their baby is not their baby. So it's really important that we get help really quickly for these women and their families. And hopefully we can access that help in mother-baby units where they're available to keep the mother and the baby together at that time. But really important that inpatient care is sought really quickly.
So just returning for a moment to the much more common problem of depression and anxiety in pregnancy, what do we know from your research and expertise about long-term outcomes for babies from that illness being present during pregnancy?
Yeah, look, I think that some of the early research, identified some really sort of significant concerns around what impact it may have on babies and children. But more and more recent research, and particularly as we get higher quality research, more detailed research, what we show is that it's a number of risk factors that lead to poorer outcomes for children. And when I'm talking about poor outcomes for children, I'm talking about developmental outcomes, so how they go in terms of acquiring all of those skills that are really important in early childhood and middle childhood. And I'm talking also about social and emotional well-being, so how children are functioning in terms of their behaviour and their feelings and how they get on with their learning in essence. So the early research seemed to suggest that maternal depression and anxiety might have an impact on that on children if it's left untreated. But more recent research, and certainly our research, suggests that depression and anxiety alone are not likely to have a big impact on a child's functioning or indeed the relationship between that mother and baby. It's really when you start to accumulate lots of risk factors. So if there's a lot of trauma in a family, if there are a lot of really difficult circumstances in terms of their social circumstances, the support levels from partners and wider family and the community, certainly if they're having to make great moves such as refugee families and things like that, that's when we start to see those sorts of impacts that go hand in hand with depression. But depression alone may not have any influence. And the most important message, I think, is getting treatment early. So we certainly know that once people are treated, once women are able to be treated and to get well and to feel confident again around parenting and their baby, that's certainly that's not going to be detrimental in the long term.
Yeah.
I'm sure that will help a lot of people, Megan, because there's just so much guilt, isn't there, around how you feel during pregnancy and then how you might be afterwards, like things that you perhaps can't help without medication, so depression during pregnancy. And I don't think that that's really helped by the community or social media, and people think that, if you're sad, then you're going to make the baby sad or whatever it is. But I think that will give a lot of people peace of mind.
Yeah, there's so many myths around, aren't there? Like that myth around if you're sad, the baby was sad. Of course, everyone feels up and down, and pregnancy can be, a really stressful time physically, emotionally, huge amounts of changes in people's lives. And of course, there's going to be moments of great joy, but also moments of stress and sadness. And so, adding on to that, the feeling that somehow that's going to be impacting on their baby is just really unhelpful. And really not borne out in the research at the moment.
Well, that's good to know that it's not borne out in the research, isn't it? Because it's a persistent belief that my patients will bring up themselves. I'm doing some sort of harm to my baby by feeling this way, and so you touched upon before about it's certainly not supported that there's any problems if appropriate. A treatment is undertaken. What do we know? What's the current status of that with particular reference to depression and anxiety? Because it's pretty common for people to come into a pregnancy on medication for depression and anxiety. And the standard advice that I put my hand up, I give to people is stay on it.
Absolutely. So I think, always the approach to depression and anxiety for any adult is that for mild to moderate, we always opt for psychological treatment first, and psychological treatments are extremely effective. So really important for psychologists and others that this is a really important opportunity to intervene effectively with evidence-based psychological interventions. But for some women, either that is not enough alone, or they have more significant symptoms. And so that's when medication, when antidepressant medications can be enormously effective. And again, the research initially, we were very concerned, what would this do in terms of exposure of the baby? But the research of late has not shown many significant findings. We have medications that have extremely low placental passage, so that's the amount that crosses the placenta to the baby. We have options where that's extremely low, so even the amount of exposure is minuscule. We have certainly data now, and our study has followed up children now to 8 years of age, and we're not seeing any strong trends around developmental concerns, around social and emotional concerns in these children exposed. There were some concerning studies that found some adverse outcomes early on, but again, as they've been replicated and as the quality improves, then we're not seeing as strong signals across any of those studies. So it's a really reassuring space. So it's still important that whoever is prescribing and the woman have that discussion, that informed consent discussion, so she's aware of what is and isn't known at that particular moment in time in the research. But by and large, for most people, the benefits will outweigh any risks that are known at the moment. So, and really important that people are treated and are supported to access treatment.
Yeah.
When I think about other areas of health, we automatically will say that's important to get that health condition treated, but we are sometimes a little bit more ambivalent about mental health. So I think it's about really giving women that message of the importance of their mental health for all of their health.
We're talking mostly about the impacts on a baby if the mum's taking antidepressants or anti-anxiety medication. Are there any impacts to her during a pregnancy, taking any of that medication?
So it's the same side effects and impacts as there would be outside of pregnancy. There's nothing in addition in pregnancy. There are some small studies that suggest some classes of antidepressants may increase some risk factors in pregnancy. But again, I wouldn't put a lot on that research at this stage because it really does need what we call replication, which is more and more studies to find the same thing before we're really convinced of that. But if women are concerned, it's important to have that discussion with whoever's prescribing and make sure that the medication that they're on is the right one for them in terms of all of their health.
Yeah. Megan, you've reviewed, we live in Ballarat, as many of our listeners know, or well, they should, otherwise they're not listening. So it's regional, and I think in terms of perinatal psychiatrists, I think we might have one.
We do have one.
One. Still, we service a big outlying population, 200, 300,000 people, so that's not many to that ratio. So what about access? Like, how do people get access to psychiatry help?
Well, I think, again, the good thing is a bit like the College of Obstetrics, the College of Psychiatry have really taken on board the importance of mental health in pregnancy. So many psychiatrists in training will be exposed to understanding how to manage mental health concerns in pregnancy and in the postpartum. So I wouldn't necessarily say that people have to always access specifically a perinatal psychiatrist. Often general psychiatrists will have some knowledge, or they'll certainly have colleagues they can ring if they do have questions. So the most important thing is accessing help, I think, and making sure that you get help as early as possible. Many GPs, many obstetricians actually feel really confident in this, particularly, I think, as was highlighted before, if someone has had depression for some time, they're stable on treatment. So it really is just about clarifying any specific risks, benefits in pregnancy. It may be that the obstetrician or the GP feels quite comfortable to do that. So the most important thing is just seeking help from, your current clinicians, and then no doubt if they need advice, they will seek help. There are also national guidelines now to help guide clinical practice, and mental health is included in the national pregnancy guidelines as well.
Megan, if someone does have depression or anxiety for the first time during pregnancy and postpartum, Are they more likely to have mental health issues for the rest of their life?
Look, it's always really difficult to predict. So we think about depression really across adulthood in terms of if you've had one episode, how likely you are to go on to develop it. If you've had 2 episodes, 3 episodes, really hard to know. But certainly over the years, I've seen some women who develop depression and anxiety in pregnancy or in the early postpartum who don't seem to go on to have many issues with depression. It does seem to be something around that time, and all of the changes, and we think about the enormous changes that go on in the body and how that might influence, as well as the social changes and life change and the transition to parenthood and all of these things, that for some reason some women are only vulnerable around that time. But for others it is a marker that they've developed a depressive illness, and so they may at other points of stress and other points of life may develop this later down the track.
We've talked about the risk of developing a problem. Does the data say anything about protective factors? Do we know anything about personal characteristics or behaviours in pregnancy that are likely to be protective against the development of a significant mental health problem?
Yeah, well, certainly in general, I guess all of the things that, certainly if people already have depression and anxiety, making sure that they do have treatment, that they are well going into pregnancy, that will reduce the risk substantially of having any relapse in pregnancy. Being well in pregnancy reduces the risk of any relapse in the postpartum. And general lifestyle issues are more and more being recognised as being important in terms of depression and anxiety. So healthy diet, exercise, making sure people manage their stress levels, all of these sorts of things. And I certainly think specifically around the perinatal period, the importance of support, the importance of those relationships with partners, relationships with wider family, support, are all really important around that time as well.
Pat, do you often get people who don't recognise the signs and symptoms of depression or anxiety themselves in your consults? And if you do, what are those sort of red flags for you that you see?
Yeah, it's a good question, because I think that's I think I could divide into 2 groups. The antenatal, the pregnant group, are used to feeling give or take like they usually feel. And obviously the pregnancy is a big deal, but they would probably recognise significant mental health changes if they were happening pretty quickly. The group that I find aren't recognising it and are less likely to report it are the postnatal group, because there's this huge overlap between the reality of life for new parents in the first 6 to 8 weeks in the absence of significant pathology versus if there's a significant mental health problem. And I think it can be hard for people to pick it.
Because they're sleep deprived or new change in circumstance.
Yeah. So there's an old-fashioned teaching model in the medical world about the sort of a red flag system, like it's not normal to want to kill yourself and it's not normal to want to harm the baby. But the more subtle things, people sometimes put it down to ups and downs of a newborn and the sleep deprivation, whereas when I hear it, they might be talking about something that I'm actually quite worried about.
And I suppose you can do it because you've had a number of years in the trade now. But are there sort of pro formas or anything that the researchers said, well, this is a really good way of saying to someone, look, that behaviour is symptomatic?
I think certainly there are screening tools, so really commonly now used in pregnancy and the postpartum are screening tools like the Edinburgh Postnatal Depression Scale, which can also be used in pregnancy, or the antenatal risk questionnaire. So there's a number of different screening tools that can be used, and sometimes I think they're always good. They're sometimes just used to screen and then people are referred on, but sometimes I think they can be better used to sort of screen and then have a conversation. So this is what, you've reported on this, but, you tell me a bit about what's going on for you. Because people's lives can be complex and there can be lots of things driving stress. It may not be depression, anxiety, there might be other things going on. Grief, for instance, often can get picked up on some of those screening tools, or other life stress stresses that are not to do with depression and anxiety. I think the other thing also for us always to remember is it is a big time of physical changes. And over the years, there's certainly been times where, significant anemia, for instance, or in the postpartum thyroid changes can lead to depressive-like symptoms. So it's really important that we keep that open mind about what's going on when there is a change for women. But I think it's just important to have those open conversations. Women will often be aware how they're travelling. But I agree, the postpartum, that first sort of 6 to 12 weeks, can be, especially for the first time parent, enormous change. The day and night and the sleeplessness and the sleep deprivation can be really hard, particularly if it's a very unsettled baby, to distinguish that from depression. But again, some of those symptoms, like how you feel about the future, whether everything sort of feels grey and heavy, or whether it is just feeling like often I'll use the analogy of jet lag. Does this feel a bit like, when your body clock's all out and you're much more likely to sort of cry at the sad ad or feel very reactive and, emotionally and all of that because you're feeling really stretched from being tired, versus that feeling of kind of bleakness and that nothing's going to get better and all of that. And sometimes some of those kinds of analogies can be really helpful for women in their own mind to be able to think, is it more than just feeling how I would feel if I didn't sleep for a number of days? Is there something more going on, or does this just feel like me when I'm really tired and stretched and all of that? Because usually people have had some time in their life prior to having a baby where they've felt tired, they haven't got sleep for a number of days, and they know that kind of feeling of feeling stretched versus that different feeling that can come in with depression and anxiety.
I love that analogy of jet lag. that does make sense, because it is that there is a distinct difference, isn't there, between feeling just like, a very, very good long sleep would solve a lot of your problems, to that bleakness. Yeah. Megan, I think you've given us so many tips for people I think everybody should listen to this episode, because it may impact you, it may not, but it's incredibly common. And for all of us to have a better understanding of our mental health and our mental health as we go into pregnancy and postpartum is really key. I want to finish with my question. Have you got any more questions before I ask my last one? Okay. You're such a massive academic, and I love it. Like, you've really put a lot of new research into the world.
We read all your bio, which is very long.
Yeah, very long.
And we're so appreciative that someone with your expertise is out there, doing this research with the necessary rigour to help people, with the problem that we see every day. But it's so reassuring to have the data behind our advice.
Yeah. So my question then is, from an academic perspective, what are you most excited about? What can we leave our listeners with where in the world of women's health research, you're really excited that this is going to come into the world soon?
I am really excited that what we're learning through the research is, I think what we've always known is that there are many ways to be a good parent. And for those who do suffer from mental health concerns, from depression, anxiety in pregnancy or the postpartum, or have had it in the past and are worried they're going to develop it again, it doesn't mean that this journey isn't going to be a really positive one for them and for their child. And I think that's a really good message. It's an empowering message. It's about seeking help and getting the support that you need, but that knowing that this can be, the same journey as for any woman, not feeling that there is some sort of inevitable harm or inevitable challenge that they're going to face. It is really just about getting the support you need.
Great. Well, if anyone is also interested in listening to another episode that we've done, we interviewed a woman who had gone through her pregnancy with bipolar, and her story is really great to dovetail with this, I think. I think it gives people a personal account of how that was for her. So, Megan, thank you so much for joining us today. We'll put some links in the show notes. You did mention a few things. We'll get onto that. So if anyone needs further sort of direction, they can go there. But, yeah, thank you so much for joining us today.
Thank you.
Thank you.
Well, thank you everyone for listening to our interview with Professor Megan Galbally. We hope that it was really informative.
Yeah, I'm just really, when I interact with someone who's at the top of their game in a particular field, I always get this feeling of gratitude that there's someone out there doing such important work so well.
Yeah, and I feel great that, because we're a medical-based podcast, that when we tap these people on the shoulder, they say, yeah, we'd really love to come on and talk to your listeners. So, yeah, I'm pleased that has happened today. So thank you for joining us. Thank you for all of your DMs and engagement on Instagram. I'm loving hearing from you all. And if there's any other questions or podcast episodes or anything that you want us to cover, we're all ears. Just send us a DM. And if you love our content, we'd really love it if you gave us a 5-star review on either Apple Podcast or Spotify, wherever you get your podcasts from. And until next week,
thanks for listening, everybody.
Keep well. Bye for now. Hey, even though Dr. Pat is, a doctor, and we get lots of other doctors and other experts on our podcast, I just need to remind you that this podcast is for informational purposes only. We share lots of medical insights and experience, but everything we talk about is general in nature and may not apply to your specific situation. Please always consult with your own healthcare provider for your individual medical advice when you grow your baby.